Welcome to the Demystifying AI in Radiology Clinical Practice podcast, brought to you by Applied Radiology. I'm your host, Dr. Avi Sharma. And today we're at RSNA, and I'm joined by Dr. Larry Tenenbaum and our guest, Dr. Greg Sorensen. Thank you for taking the time to join us today. Love for you to give us a little bit of background, and then let's get started. What are you doing with AI today?
Yeah, great. So the background is quick. I'm the Chief Science Officer at RadNet. RadNet acquired my company, Deep Health, about 5 years ago. And so now I work at this large outpatient practice. I actually hadn't heard of RadNet before I kind of got into industry because I was an academic, and RadNet's only in 8 states, but they're a large outpatient imaging provider that Larry has worked at for a long time. And we are absolutely, totally focused on AI and really doing a lot there. And in fact, maybe this is the wrong thing to lead with, but I would say as I've looked around at what is happening in the field, RadNet, I think, has actually invested more in AI than any other company. Last count was over $500 million just in AI. And so we are super into it, and we're seeing tremendous benefits from it. So I don't know if you want me to dive into a couple of clinical examples, but I've got them.
I'd love to, especially because, people say they do AI, and so many people just use it as a buzzword.
Right.
And honestly, let's get granular.
Yeah.
Tell me more about what AI tools you're using in practice.
Okay, so let me tell you a couple that have had big, like tens, if not hundreds of millions of dollars of impact in AI tools. The first one was the one I started with, which was mammography. We just published a study two and a half weeks ago in Nature Health, which is the largest breast AI study ever done in the United States. Over 500,000 women, with and without AI, and we showed a 21% boost in cancer detection rate. And the secret there was actually something that has been really insightful for us at RadNet. It's the point solution of the AI. So it was a really great algorithm, a CAD-EX cleared algorithm, but it was also a change in workflow. We didn't use AI to keep doing things the way we've been doing them. We changed the way we were doing things with AI. And specifically in this case, we introduced something called a safeguard review, where the most dangerous cases that the first radiologist, for whatever reason, doesn't recall, we ask a second radiologist to look over her or his shoulder and take another look. So we kind of get the best of the European double reading mammo approach, but only for about 8% of the mammograms, which the AI selects for us. And most of the time, the second doctor agrees with the first time. But it happens enough that they disagree that we're finding this big boost in cancer detection. And while that was initially just the AI, if we didn't control the whole workflow, it never would have worked, like in the real world. And let me give you a specific example. As you probably know, if you've ever dictated mammo, there's a lay letter that has to go out. And that typically goes out as soon as you hit sign on your wrist or your PACS, right? And then the later letter is just automatically sent out. Well, if we're going to bring in a second doc and I have to adjudicate with you, like who was right, what do? Do we issue an addendum? And does the first doctor look like they were missed something? Well, no doctor would want to be involved in that workflow. So we had to stop the lay letter process, build an adjudication tool, get that adjudication to work all in the wrist in order to take advantage of the AI, which we did, and it's totally awesome. And it's causing this big win for cancer detection rate. It's been so powerful that we've actually then followed the example of DBT. You may remember when DBT came out, it wasn't fully reimbursed by all insurers. Medicare did, but some insurers wouldn't. So we actually, not me, but the predecessors asked women to pay for DBT if they wanted it. Exactly. And I remember my friends at NYU said they charged $75. I think at RadNet they charged $50, maybe something like that. And so we thought, well, let's follow that example because women are kind of used to it. So we asked $40 to have that second reader, involved, and the AI, and 45-50% of the women say yes.
So that is a fantastic story, and there's actually a few points I'd love to get into a little bit more. One part is the augmentation of the workflow.
Yes.
I think ultimately, in the experiences that I've had teaching AI to radiologists, when things have been done a certain way for so long, introducing this new novel pathway, it really boggles the mind.
Exactly.
And it obviously makes sense, right? Instilling confidence in the solution actually making an impact. Ways in which I've felt like there has been is collecting that said data, which you've done, and really showing it to them and say, the proof is in the pudding.
Yes.
This is how it works. And would you agree that gradual buy-in has happened across the practice?
It has, and it took some serious work. And I've had my biggest skeptics become my biggest fan.
Yeah.
Because they initially were like, hey, I've been doing this for 30 years. You have this stupid program you wrote over the weekend, they think, right? And yes, it's FDA cleared, but like, I'm still the expert here.
Right.
And when we could show them cancers they had missed,
Yeah.
and then when they were the second reader and they saw their own case, we had 1 or 2 cases where the woman was, where the doctor reread her own cases, which we didn't usually happen, but for some scheduling reason. She's like, oh, I missed this.
Yeah.
And then they were like, ooh,
Yeah.
you know, this thing actually, and so now I started getting love letters. It was like, I'm so great because you saved me from missing a cancer.
Exactly.
And then they're like, okay, now I'm ready to buy in. And you have to go through that process because look, we trained for a long time. We trust ourselves. So I don't blame the kind of the barrier, but it is a barrier. And if you don't have the data to convince people that they're going to be a better caregiver if they adopt the AI, I mean, I don't blame them.
Let me ask you a question. So that's really a great story, and I was somewhat familiar with the story. That's a big impact. Certainly, with that success rate, your radiologists have to feel more supported.
They do, exactly. They're happier.
Yeah, and with less stress. You know that stress you get before you close an exam. Did I miss something?
Yeah.
Less stress. Now, with the performance that you've shown, this isn't just a paper you've done. This reflects RadNet work over the years.
Over 100 centers, yep.
With the acceptance from the radiologists who are reading these exams, you would expect that they would get some workflow benefits out of it, some throughput benefits out of it. Does it take them less time to review the exam?
It's a great question, and I've asked a number of the docs, and they vacillate on this. And I think it has to do with your point about kind of where are they on the adoption curve. Initially, it's definitely slower because they didn't used to have to think about the AI, and now they really have to think about it. So that takes more time. Over time, I think they trust it more, and then they do speed up, but some of them more than others. So I would say net, the practices feel like it's a win, and they're happy about it. But if I were going to say the ACR Commission, is this like an RVU savings in the doctor's time? I'm not sure that's there yet. Because they still have to think about the AI and at least process it. And most of them still want to spend all the time looking at the cases. I think you hit the nail on the head, Larry, when they feel more confident about the care they're giving, and that's worth something to them. But I was disappointed that we couldn't find a monetary path forward other than asking the patients to pay.
And you know what? I think you're touching on a great point because AI right now, I would view in its best case scenario, it is a safety net and it is a great tool to alleviate burnout, which every radiologist is dealing with your ever increasing volumes. But you touched on the reimbursement pathway and kind of ultimately where you might eventually see it going because as you alluded to, it is something that is an additional cost.
Yes.
And who pays that cost? Who pays for the ROI? Is it the academic health center?
Right.
Is it the patients?
Look, we had a lot of internal debate, and I would say I felt bad about asking patients to pay because then by definition, some patients aren't getting this AI that we know is awesome.
Right.
However, we just saw the story with DBT and realized if you don't kind of shame the payers into paying and apply essentially political pressure. So we have now employer groups who pay their own healthcare cost, and they're saying, look, I see all my employees, half of them are paying out of pocket.
Right.
Why don't I just call this a benefit?
Right.
And then their employees are happier. So we've got 4 or 5 groups now that are doing that, and I think it's eventually I don't want patients to have to pay.
Yeah.
But this is the only path I can see in our crazy system to actually get to where the insurers would pay.
That's a great. I've actually seen that avenue via mental health benefits that I've seen through bigger corporation companies.
Right.
If you
then
push
they're like, okay.
And in the meantime, you're collecting data that further supports why this should be covered.
Why they should do it.
That's great.
And it's a wacky. Like I used to think MR physics was complicated. Healthcare rereimbursement in the U.S. super complicated, right?
Yeah. And
just as frustrating.
Yeah, and just as frustrating.
I love that, but anyway.
And I'd love to give your perspective. I mean, you guys have seen the revenue cycle go on and on. AI is eventually going to be a CPT code. Do you think it's going to be?
Yeah. So I have a second example for you that is kind of touches on this that we sort of stumbled into, to be candid. In June of this year, we acquired a company out of Australia called C-Mode, little company, 20 people.
Yeah.
They made thyroid ultrasound AI.
Right.
And we then put that into place at RadNet, and it was not perfect at first. But we have this co-creation model where the docs and the techie guys kind of work together. And at our scale and with the depth we have on the tech side and the size we have, it's really a lot of fun. And we figured out that the C-Mode AI basically can take the measurements off the thyroid and put it into the worksheet, and then that worksheet into the report. And because of all that orchestration we have, our doctors have gone from hating thyroid reporting, which I think most of us radiologists dread reporting thyroid, right? To actually being like, they literally accept more than 90% of the time what the AI-driven report says, because they can just see, oh yeah, all these numbers flow through, which is exactly what we've always wanted, right?
And ultimately, that is the quality benefit that is then passed down to the patient.
Right. There's less transcription errors, right? The sizes are done right. And then to your point, interestingly, we found out there is a category 3 CPT code for ultrasound tissue characterization, which RadNet, the team, started billing, and we're getting paid. Like, we're not getting paid 100%, but we're getting paid like 50+% of the time. And it's like $60. So like, wow, if I get $30 on average for using the AI and it's faster, and the other benefit, Larry could tell you about this, we took the ultrasound scan slots from 30 minutes to 20 minutes because the techs don't have to spend so long filling out the dumb worksheet. So we're doing more scanning with the same room and the same techs and the same rent. That's a win. The docs are signing faster and getting better accuracy, so they're happy. And I'm getting paid some of the time. It's like, wow, this is rock star.
These are the more tangible benefits. When I think about the imaging lifecycle, so often people think just about imaging interpretation, but between ordering, the actual scan, the follow-up.
It has to be sustainable.
Exactly.
And so you need some payment in there somewhere. And we're doing like, I think last month we did 20,000 of these. Like,
fantastic.
It's just like, it's taken off. And so now all over the RadNet networks, all the 400 sites are like, give me the ultrasound AI, because like, they hated ultrasound AI, ultrasound interpretation before. Now it's back. So we have to find more of those. Like I said, we kind of stumbled into this one. We weren't sure that the T code would work, this category 3 code, but it kind of, and who knows how long it will. But you know that way category 3 codes work. If you bill under it, it gets tracked. And then if there's utilization, people say, okay, look, people are really using it. Maybe we'll put a reimbursement on it.
Ultimately, you're gathering more data to further prove the point that, you know, AI should be more reimbursable and should be part of the pathway because it has a lot of benefits.
What we haven't done yet in thyroid, which we should do, is like better outcomes, the way we have in mammo. We do a lot of thyroid biopsies. We probably do 10,000 a year across RadNet. So, or maybe it's a good idea. We should be tracking, like, are we doing fewer of those? Are they more accurate?
Those are the
like
stuff where I think.
Then a payer would get like, okay, I'll pay for that because I'm going to save money.
Because I'm saving money here, and that's downstream cost savings.
Can I ask a question that's going to derail this discussion?
Yeah.
You know, as we bring this discussion to a close, because we're almost at the end of our period, Deep Health pioneered this approach. What approach am I talking about? Not the one you've addressed. Is let's focus less on all of these individual potential applications, but creating an ecosystem when the electricity of AI connects everything in the business enterprise, including the clinical pieces you've talked about.
Correct.
And including, you know, the piece that I'm getting so glad I get to say this out loud, that I pioneered in RadNet, which was your Tech Live, you know,
Tech Live is totally awesome. Yes.
And I've actually experienced it at the level where we started this as pilots, all the way through the implementation, and it is absolutely astonishing.
I'm so glad you brought this up because it was the third example I wanted to talk. It's sort of more future AI because it's not yet fully AI powered, but it is where I think things are going. So Tech Live is basically a remote operations command center kind of thing, right? Where you can remotely scan, and we have now built our own version of that. That's what it's called, Tech Live. We've got it approved for not just MR, but CT, PET-CT, ultrasound.
Great.
And that lets you do two things. One, you can get expertise in. This is what Larry was so helpful on. So you could get expertise in to help somebody do a crazy cardiac MR. Or like, I just heard this great story from our ultrasound tech, chief ultrasound tech. We had a remote site, single lone tech, was doing a 7-week pregnant woman, couldn't find the heartbeat, was starting to stress out, was a tricky patient. She didn't know what to do. She calls over Tech Live for our super tech, or kind of our senior tech. She's able to take over the scanner because the Tech Live thing isn't just a screen. It like lets you run the machine, all the buttons, and she finds the heartbeat. And she takes the picture, calms everything down, no repeat visit. Everybody's happy, right? And like, wow. Now what we want to do is we want to AI enable that video stream. So when the MR scanner shows the patient's going in foot first, but the wrist says, oh, this is the brain, you're like, hey, shoot up a flag. And so instead of running 2 or 3 scanners, which is what the techs can do today, they could run 5 or 6, right?
That's fantastic.
That would be totally awesome. And that, I think, is where the puck is headed.
You know, it's funny because you, in essence, answered how I typically wrap up this podcast. First of all, I want to thank you for your time. It has been a pleasure speaking with you. And RSNA, ultimately, it is always a zoo. So
it is a zoo.
It's always
fun to meet new
fortunate
people,
to
though.
catch people and catch up. But ultimately, that's how I wrap up the question. I ask you, where do you see AI going? What is your crystal ball on where things are going?
When I started Deep Health, I had this cheesy tagline, bringing the best doctor in the world to every patient. And I actually think that AI could do that. Like the best breast imager, I want her looking at my wife's mammogram.
Exactly.
Right? And wherever she is, or that mammographer is, I want to distill all that expertise into a really powerful piece of software and then deploy that on a medical image. And let's do that for mammo, let's do that for lung cancer, everything we do, that's going to take a long time. Right? I think I'm going to be retired before it actually happens.
Right.
But that's the direction.
It's funny you mentioned that, and I do see that where it's going. I mean, I'm an early career radiologist, but ultimately, radiology in and of itself is going to change dramatically over the span of the next 5, 10, 15 years.
But I think for the better.
It is for the better.
You're going to be in charge. Like, who's going to take your job away from you?
Right.
You will be the one to say, hey, look, this one's working and that one's not.
Right.
I can guarantee, I think it's going to, I tell this story too. When I was young, kind of your stage, MR was brand new.
Right.
And in fact, it was so new that it wasn't called MR.
Yeah.
You don't remember, it was called NMR.
Yeah.
Which stood for no more radiologists.
Yes.
And the thought was, it's so obvious to see that the radiologists are going to get cut out of the loop and neurologists will run all the MR scanners and we'll be all out of a job. It's been the exact opposite. MR has been the best thing for our specialty.
Yes,
and I think AI is going to exactly do this.
I love that sentiment. And as you advocated for, human in the loop. Ultimately, AI is at its best when a human is in the loop.
Now, where in the loop, we get to decide, right? And I think for some, like in some of our mammograms, it's actually better if a doctor doesn't look at them because they're nervous and they hallucinate a cancer that's, because maybe they were pursued recently. And so you can actually show, hey, look, for these class of patients, because the recall rate would be high if you showed it to a human and there's with no benefit, it's better for these not to be looked at. I think we're going to see a bunch of studies like that.
Right.
But still, ultimately, the human has to oversee that, right?
Exactly.
And MQSA says that, and it will always be some human will be kind of, but they're going to. It's like, when do you trust a fellow and when do you not trust a fellow? Right. Ultimately, you have to make that call, and you're going to be the responsible adult.
Agreed. AI, in my mind, is like a resident in training that gets better with
better
time,
and better. Exactly.
But again, you are the final signer as a radiologist.
Exactly. And at some point, it's going to be good. Thank you.
Greg, this has been a fantastic conversation. I want to thank you for all of our listeners and viewers for enjoying and participating in this conversation today. Greg, I hope you have a wonderful rest of your
Thanks so much,
RSNA.
Ami.
Thank you
Great
again for
meeting
this
you.
conversation.
Absolutely. Thanks so much.
Thanks all.